Thank you, everyone, for joining tonight. We're honored to have you on this call, and we're honored to have Dr. Alan Schwartz with us this evening. Dr. Schwartz is a world-renowned sleep medicine specialist with innovative, patient-centered approach to diagnosing and treating sleep disorders. He has held leadership positions at Johns Hopkins Sleep Center for over 30 years. He previously was director of the Johns Hopkins Sleep Disorders Center and is currently part-time adjunct professor at the University of Pennsylvania in Vanderbilt. Before I turn it over to Dr. Schwartz, just a couple reminders for this webinar. Everybody is muted and your video is off. If you have questions, please submit those in the Q&A section. We'll leave time at the end of the presentation to answer any of those questions that you may have. So I'm going to go ahead and turn it over to Dr. Schwartz. We are really thrilled that you can be here with us.
Thanks so much, Jamie. I really appreciate it. And please tell me if you're having any problems with audio or transmission.
You sound great.
Thanks. Terrific. And actually, don't hesitate to interrupt if there are any questions, burning questions or concerns or technical issues. Going to talk about central sleep apnea and chain stroke breathing. Learning objectives here are briefly stated. Discuss the pathogenesis, the polysomnographic and clinical impact of the disorder, and highlight the role for the transvenous phrenic nerve stimulating system, also known as the remedē system by Respicardia. By way of disclosures, I have a number of different disclosures, but the only one really of relevance here is that I am compensated for webinars such as this by the folks at Respicardia as well. So feel free to bear that in mind. Nonetheless, I look forward to your questions and any comments at any point along the way. We'll talk about the pathogenesis, the clinical impact, the clinical recognition of the disorder, and finally therapeutic approaches. And it'll be about half of the time on the first three items, and then therapy really is the emphasis here for today to really outline some of the advances in therapy for central sleep apnea and chain stroke respiration. First, pathogenesis. Well, really, essentially, central apnea is due to the fact that we blow down our CO2s below the apnea threshold. During sleep, CO2 is the major stimulus to breathing. And when CO2 goes down for whatever reason, it actually can cross the apneic threshold, at which point ventilatory efforts, respiratory drive ceases altogether. And it's only after a period of apnea, of central apnea, where CO2 rises sufficiently that it exceeds the apnea threshold, that breathing is stimulated once again. Now, we normally breathe at a CO2 of about 40 millimeters of mercury, but the reserve, the CO2 reserve, is our buffer that prevents us from stopping breathing. Well, all goes awry if we have an exuberant response to a ventilatory stimulus. As you will see, if we blow down our CO2, we will cross below the apneic threshold, shown here in the blue arrow, and you'll stop breathing transiently. And that essentially is a central apneic episode. How does that happen? Any perturbation in ventilation leads to perhaps an increase in the ventilation. And if that increase is exuberant, it blows down your CO2. And as we track that CO2, which resides here normally, well above the apneic threshold in the dashed line, as you hyperventilate in response to any perturbation in ventilation or stimulus, you blow down your CO2, and as the CO2 goes down, when you cross the apneic threshold, you literally stop breathing or have a central apnea, a prolonged expiration or central apnea for a period of time. Breathing only resumes once the CO2 accumulates and or you rouse from sleep. Either one of those stimuli will cause an increase in ventilation as the CO2 climbs back up to the baseline level. Now, this response to CO2 can be exuberant, and we call the response to CO2 actually the loop gain. that causes periodic breathing. Loop gain is defined here on the bottom of the slide as the response in ventilation to any disturbance in ventilation away from the mean or the homeostatic level of ventilation. And when that response is exuberant in either direction, the loop gain is said to be elevated, and it's in response to that elevation in loop gain that we tend to over and undershoot in the level of ventilation that ensues. Now, there are several causes physiologically for increases in the loop gain, 3 in particular. There's the controller gain, namely the sensitivity of the intrinsic ventilatory control centers in the brainstem. There's circulatory delay that leads to a mismatch of CNS ventilatory control to the levels of gas concentration in the central circulation. And then there's finally the plant gain. The plant gain is literally the efficiency with which ventilation succeeds in excreting CO2 from our system, from our lungs. And as the plant gain goes up, as we become increasingly efficient in blowing off our CO2, it has a direct impact on loop gain, causing an increase in loop gain that leads to or can promote the development of central sleep apnea or Cheyne-Stokes breathing. Now, these 3 physiologic causes of central sleep apnea and Cheyne-Stokes respiration have clinical correlates. And the clinical correlates are briefly shown here. Controller gain, any conditions that cause ambient hypoxia, as in high altitude exposure, or hypoxemia in patients with cardiopulmonary or neurologic disease, can cause an increase in the controller gain. Circulatory delay is oftentimes precipitated by an increase in stimuli coming from hemodynamic factors in patients with congestive heart failure or atrial fibrillation. And finally, the plant gain, as we'll soon see, can increase as a result of a variety of medications or CO2 accumulation. Medications such as opiate lead to a greater efficiency of CO2 excretion from the lungs. That is represented by an increase in plant gain and an increase in the overall loop gain of the ventilatory control system. Heart failure, as an example, is a classic example in which Cheyne-Stokes breathing and central sleep apnea occur. Why does it occur? Well, heart failure itself is associated with pulmonary vascular congestion, and the hemodynamic changes generally make our lungs wet and boggy, cause us to blow down our CO2. There's stimulus from excess fluid in our lungs, and as a result, a lower level of baseline CO2 decreases the overall ventilatory reserve, the CO2 reserve that buffers us from having central apneas or crossing below that apnea threshold. Clinical impact. What's the difference if you have central sleep apnea and Cheyne-Stokes breathing? Well, the answer is there's a heck of a difference here. Looking at this one cohort, an NIH-sponsored trial looking at survival in a heart failure cohort with reduced ejection fraction. These are individuals who are predisposed to central sleep apnea, and we're contrasting here those with heart failure, with and without central or obstructive sleep apnea, to those who have no or very minimal sleep disordered breathing. And we find in this cohort of several hundred individuals that those with untreated central sleep apnea in the setting of heart failure have a greater than 2-fold increased risk of mortality, shown here on the survival curve, the red curve showing increased mortality or decreased survival in those with central sleep apnea and Cheyne-Stokes respiration over a 3-year period of observation. Obstructive sleep apnea is almost as bad. if you have heart failure and obstructive sleep apnea, you should also be paying attention to the fact that there's an increased risk of death as a result of simply being marked with sleep apnea of either type. It's not only death or mortality that takes a toll. It's heart failure readmissions within the first 6 months. And those who have central sleep apnea have a greater than 50% increased readmissions rate in the first 6 months after the detection of the disorder. And a single readmission, you're predisposed to a single readmission at greater than 50% of those heart failure patients that have central sleep apnea. But multiple readmissions occur in greater than 25% of those who have heart failure and central sleep apnea, with a very highly significant hazards ratio, increased risk, if you will, of heart failure readmissions just by virtue of the fact that you have central sleep apnea. Well, it's for good reason. It's the fact that patients with central sleep apnea and Cheyne-Stokes respiration experience increased cardiovascular stress. It's not only the association between these two disorders, but it's really the fact that central sleep apnea and Cheyne-Stokes respiration is a causal factor increasing the overall cardiovascular stress. What does the stress result from? Well, it results from the fact that apneas and hypopneas are associated with intermittent hypoxemia and recurrent arousals from sleep. As a result of the arousal, sleep quality, sleep efficiency deteriorates, and as a result of a drop in sleep quality, cognitive function and daytime function in general deteriorates as well. Not only that, but because of the intermittent hypoxemia, you see that there's increasing levels of inflammation that are stimulated, cardiovascular ischemic events, and because of the intermittent arousals and responsive carotid bodies to intermittent hypoxia, there's an increased sympathetic drive, overall surges of sympathetic activity that accompany the hypoxemic and the arousal periods. And it's really as a result of those jugs, if you will, in sympathetic activity, surges of sympathetic activity, that really ultimately there's increased cardiovascular stress. And it's because of that, not only do we see clinical sequelae of nighttime sleep disruption, literally diminishing the quality of life during the daytime, severe fatigue, daytime sleepiness, cognitive impairment, depression, and memory deficits. All of these are in part a result or exacerbated by the fact that the quality of sleep is interrupted at night. But it's also the fact that untreated central sleep apnea increases your overall cardiovascular stress and the risk of untoward cardiovascular events. We find that central sleep apnea increases rates of heart failure readmissions, as we spoke about a moment ago, and increases the risk of developing increasing paroxysms of atrial fibrillation. Twofold increased risk of heart failure admissions, as we mentioned, and heart failure mortality. And so this is really a serious marker and a cause for worsening morbidity and mortality in those who have underlying cardiovascular disease. Why does this happen? Well, really as a result of these surges of adrenergic activity that pummel the patient repeatedly over the course of the night. There's pump stress on the heart itself, and over time, cardiac remodeling occurs, leading to impairment of left ventricular function and left atrial dilation that predisposes to recurrent episodes of atrial fibrillation and episodes of atrial fibrillation that do not respond to cardioablation procedures if the sleep apnea itself goes untreated. and it's a result of central sleep apnea that heart failure worsens, accelerated progression of heart failure leading to increased hospitalizations and ultimately increased mortality. Well, we've commented about the clinical impact, but how do we recognize this disorder? Well, there are clinical factors that really characterize the large majority of patients with central sleep apnea and Cheyne-Stokes respiration. In fact, most of the patients with central sleep apnea that present to sleep laboratories, not to cardiologists, do not actually have heart failure. Who are these patients? We see here 3 cohorts that are represented: a Veterans Administration cohort, a large cohort, a detailed French cohort that has been recently put together showing the clinical characteristics of those who present to sleep labs with central sleep apnea. And finally, the famous Sleep Heart Health Study, a large-scale epidemiologic study that looked at sleep outcomes and sleep disorder breathing as predictors of a variety of other cardiovascular and comorbid events. These cohorts in the main show us that central sleep apnea generally occurs in people who are somewhat elderly, somewhere in their 60s, and predominantly in men. The BMI is generally not quite as high as it is in patients with obstructive sleep apnea. These patients across these 3 cohorts tend to be mildly overweight or mildly obese, with BMIs on average in the high 20s. Yes, they have a combination of various cardiometabolic comorbidities, hypertension, diabetes, and history of myocardial infarction. But the main risk factors, if you will, the main characteristics are those really cardiovascular characteristics that predispose to this disorder. So those who have a history of atrial fibrillation constitute anywhere between a fifth to a quarter of the patients with central sleep apnea. Those with history of stroke and heart failure are anywhere between 15 and 25% of those who present to sleep labs with CSA. And then finally, an increasingly recognized group of patients are those who are on chronic opiates, represented here by methadone, but a variety of opiate analgesics, and as we'll see, a number of other respiratory depressants really predisposed to central sleep apnea and Cheyne-Stokes breathing. How do we recognize it on sleep studies? Well, these cartoons really illustrate the spectrum from obstructive to central episodes. Obstructive episodes classically represented by a cessation of airflow during sleep associated with increased efforts and a desaturation. Mixed episodes have a combination of the loss of respiratory effort followed by a few or a couple of obstructed breaths, leading to an arousal and a desaturation. As we get into pure central sleep apnea, we have a classic Cheyne-Stokes breathing pattern represented by a waxing and waning contour in both airflow and effort, with the central apneas punctuated by periods of waxing and waning hyperpneas. This waxing and waning pattern tends to be associated with a much more sinusoidal pattern in the oximetry tracing, very much unlike the more asymmetric pattern in oximetry that characterizes the obstructive and the mixed episodes. These episodes are associated with a gradual desaturation, but a very abrupt resaturation back to baseline. There are other types of central apneic episodes, not just the waxing and waning of Cheyne-Stokes breathing, but also a very symmetric central apnea pattern where there's a sudden stop and start of ventilation shown here with 2 or 3 unobstructed breaths during the arousal phase that punctuate these abrupt central apneas characterized by the cessation of breathing suddenly. These episodes can be very short, 8 to 10 seconds in duration. When they're often associated with brainstem injury or pharmacologic effects of CNS depressants, such as opiates. It goes under the name oftentimes of Biot's breathing, or if you're French, Biot's breathing. You also see this pattern at high altitude where ambient hypoxia brings out increased controller gain and a purely central apneic pattern. And then finally, those with low brainstem injury can have an ataxic breathing pattern characterized by fits and starts, some central episodes with erratic patterns of ventilation intervening. This is an ataxic breathing pattern, which invariably indicates that there's some relatively low level of brainstem injury. Therapeutic approaches. There are, as we've discussed the pathophysiology of central sleep apnea, we can tag specific therapeutic approaches to the underlying pathogenesis of the disorder. And I'd like to really highlight 4 of them here. First is the circulatory delay that is oftentimes an accompaniment of atrial fibrillation or congestive heart failure. Clearly, treatment for central sleep apnea and chain stroke breathing consists of really optimizing the treatment for the underlying cardiovascular problem. If it's atrial fibrillation, discussing medical or procedural ways to cardioablate and reverse atrial fibrillation from the get-go. If it's heart failure, the pharmacopoeia for treating patients with heart failure is front and center. It includes diuresis, it might include afterload reducing. New agents like Entresto have moved the bar even further, and the Giardians and other pharmacotherapy that really essentially promote diuresis and maintain the patient in good fluid balance and unload the heart. These are all associated with improvements in heart failure status and improvements in central sleep apnea and chain stroke breathing. We can also speak about the primary factors that increase the overall loop gain and the tendency of the system to develop periodic breathing patterns, namely central apneas punctuated by intervening episodes of hyperpnea. Let's look at plant gain. There are limited data with respect to plant gain, controller gain, and other mechanisms for stabilizing ventilation, as we will soon see. What is plant gain? Plant gain literally represents the efficiency with which we blow down our CO2. How much ventilation does it take to decrease the CO2? Now, the bottom line here is that if you're hypoventilating, you're down here on this curve relating ventilation, minute ventilation to CO2. If your CO2 is elevated, you're off to the right-hand side of this curve. It takes very little decrease in ventilation on the y-axis to blow down your CO2 a whole lot. And if it only takes a minor perturbation in ventilation to blow down your CO2, you will cross the apnea threshold and you'll stop breathing, literally have a central apnea. Well, this is really what happens when patients are put on various CNS depressants. They're shown here, the major categories on the left-hand side. Opiates such as methadone, morphine, and codeine will lead to some degree of hypoventilation, particularly during sleep. These are agents that move us down this metabolic hyperbola, this slope here, and lead to an increase in plant gain, an increased efficiency with which changes in ventilation alter or blow down the level of CO2, leading to central sleep apnea when CO2 falls below the apnea threshold. Other CNS depressants, sodium oxybate, often given for patients with narcolepsy. Well, there's overlap between narcolepsy and sleep-disordered breathing. And so be on the lookout for those patients that you might be treating in the sleep center for narcolepsy and putting on sodium oxybate to stabilize their overall sleep patterns. Baclofen, oftentimes prescribed for muscle spasms in a variety of neuromuscular diseases and in general. Baclofen can decrease the ventilatory control mechanisms or response in ventilatory control, but it increases the plant gain by moving us down this metabolic hyperbola. Anti-epileptic migraine drugs or drugs that are being used for treatment of serious depression or bipolar disease, these also are associated with an increase in plant gain and increase in central sleep apnea. The gabapentin and pregabalin medications, often given for neuropathy, neuropathic pain, and also mood stabilizing purposes or anti-epileptics. These are also associated with some degree of ventilatory depression that can predispose. And finally, new to many of us is the fact that antiplatelet agents, for unknown reasons, can be associated with an increase in plant gain and increased tendency for developing central sleep apnea. Well, it's as a result of this that we want to perhaps reverse the increase in plant gain, and we can do that in part, but to a limited extent, by administering low doses of acetazolamide. Acetazolamide will tend to blow down your CO2 a little bit, move you up this metabolic hyperbola, and as you move up just a teeny bit here, you're actually moving to a point where the plant gain decreases. Namely, what happens here is that for any disturbance or increase, if you will, in ventilation shown here, there's much less of a decrease in the CO2. And it's because of that that plant gain drops, and we are at lesser risk of actually bumping down against the apnea threshold at which central apneas exist or occur. We can also look at strategies that decrease the overall controller gain. We said that one of the reasons for increased controller gain is really breathing at high altitude, where ambient hypoxia stimulates an increase in our ventilatory control systems in our brainstem. And so anyone that is actually exposed to hypoxia or hypoxemia can be treated with a little bit of supplemental oxygen to some marginal benefit in terms of decreasing the degree of central sleep apnea. We can also apply CPAP, which increases resting lung volumes. It increases the oxygen stores in our lungs. And with that increase in lung volume, we sometimes also stabilize airway patency. Pharyngeal patency improves. The results shown here of the CAMPAP trial, the Canadian CPAP trial from a number of years ago, show that in patients with heart failure and reduced ejection fraction of about 25%, who have central sleep apnea with an average AHI of 40 events per hour, in a randomized controlled trial comparing CPAP to usual care, showed that there is, in fact, a halving of the apneic episodes, an improvement in nocturnal oxygenation, modest improvement in ejection fraction, and in overall minimum or SpO2 naders. Over 2 years follow-up, however, there was no change in sleep disordered breathing outcomes, in quality of life, or in transplant-free survival. And so while there's improvements in central sleep apnea and in sleep apnea in general with CPAP itself, in this heart failure population, there's little improvement or no improvement, if you will, in the overall mortality of the cohort. And that really leads us to other techniques that are really essentially designed to say, well, what the heck? Whatever the cause of increased central sleep apnea and chain-stroke breathing might be, maybe we can just stabilize ventilation through these central apneic episodes. And there are really two efforts that have been built in order to stabilize central sleep apnea. One is really with a fancy type of bi-level ventilation called adaptive servoventilation. How does it work? It's really essentially a computer under the hood of a bi-level machine. And rather than being straight vanilla BiPAP, shown here on the left-hand side of the diagram, what we see here is that this machine monitors the level of ventilation and adjusts the amount of bi-level support, literally pressure support, depending on the overall level of ventilation. It seeks the golden mean in ventilation. And so when ventilation tails off during a central apneic episodes, the level of pressure support, if you will, or bi-level support will increase in order to stabilize ventilation. And when ventilation increases here to a very, very high degree, the level of ventilatory support or pressure support ventilation provided by the adaptive servo device reverts almost back to straight vanilla CPAP. In other words, this is a bi-level machine that adapts the level of ventilatory support to the level of the patient's own ventilation. In so doing, it seeks to stabilize ventilation. So during the apneic episodes, it seeks to increase the amount of air moving in and out of the lungs by applying more pressure support. And when the patient is hyperpnic, has a big response to the apneic episode, it backs off on the level to which the BiPAP machine actually is serving to increase ventilation. It backs off and no longer becomes a ventilator per se. Well, SERVE-HF was a large trial about 10 years ago in patients with heart failure and reduced ejection fraction. It was a well-designed study, randomized controlled trial that contrasted ASV versus usual care. It took patients who had moderate to severe sleep apnea with an overall AHI of greater than 15 per hour and looked at composite endpoints of death, time to event, and life-saving interventions such as transplant, LVADs, or hospitalizations. What resulted in the end of the day over a 60-month observation period is that ASV turned out to have to confer an increased risk of these morbid events, with patients who were put on active ASV faring less well, with increased mortality, death from any cause, or death from cardiovascular causes in those who were actively treated with adaptive servoventilation. It generated a black box warning that basically said ASV is contraindicated for patients who have chain stroke and central sleep apnea and reduced ejection fraction. The update on that, another device now by Philips Respironics, the Advent HF results, heart failure, showed a neutral outcome with composite morbidity and mortality shown here on the right-hand side being essentially no different between those who were treated actively with the adaptive servo device versus those who underwent usual care. And even though the AHI decreased by a substantial amount on ASV with improved oxygenation and improved sleep architecture, the overall outcomes in terms of morbidity and mortality were no different whatsoever. And it's because of that, because of largely negative or deleterious effects of ASV and very limited data in the other medical therapies that we have discussed, that really we are bereft of meaningful solutions for treating patients with central sleep apnea and chain stroke breathing. And you see here summarized that the CANPAP results were halted early because of concern about higher mortality. We've mentioned the same with adaptive servoventilation. Theophylline we haven't spoken about, but very, very limited data in a very small number of patients. Likewise with acetazolamide, while we can achieve some mitigation of the central sleep apnea in a limited number of patients, there's just simply not much data with these pharmacologic agents, or for that matter, minimal effects in a limited number of patients with supplemental oxygen. And that really leads us to phrenic nerve stimulation as a potentially viable treatment modality that can not only stabilize the breathing patterns during sleep, but can also improve sleep architecture and overall outcomes that we'll see in a moment. Well, the remedē system is a system that is designed to stimulate the phrenic nerve repeatedly over the course of the night. It is a device that is MR conditional, and it is indicated for the treatment of moderate to severe central sleep apnea in adult patients. And the only contraindication to this treatment is really that you have active infection, whether localized or systemic infection for whatever reason. What does the system consist of? Well, it is a transvenous pacer for the phrenic nerve. The system itself is fully implantable, as mentioned, indicated for treating patients with moderate to severe central sleep apnea and Cheyne-Stokes respiration. It is designed to stabilize the breathing patterns during sleep by stimulating the phrenic nerve, thereby activating the diaphragm, generating a negative pressure the way we normally do during normal tidal breathing. There's a degree of automaticity that is uncommon. It turns on automatically at night under certain conditions, and it's because of the automaticity that nightly compliance and adherence is assured over time. The components of the system: an implantable pulse generator that is implanted in the usual place, usually below the clavicle and the subcutaneous tissues. Pulse generator has a power pack, generating algorithms that generate repeated pulses that stimulate the phrenic nerve. And the phrenic nerve is stimulated transvenously, usually on the left side by inserting a transvenous pacemaker wire into the left pericardiophrenec vein. This vein runs right alongside the phrenic nerve and easily stimulates the phrenic nerve repeatedly to take normal respiratory efforts. If the pericardiophrenec vein is not accessible, the stimulating lead can be put in the central veins, the innominate or superior vena cava, and stimulate the phrenic nerve on the right side in much the same way. The right brachiocephalic vein is the location for this transvenous pacer. The phrenic nerve stimulating transvenous phrenic nerve or remedē system activates the phrenic nerve in an automatic way. And it does so in an interesting way, that is pre-programmed as follows. The first thing you do is you set a therapeutic window. Literally, generally speaking, when are the hours that the patient tends to sleep? Let's say you have a patient who generally sleeps anywhere between the hours of 11 p.m. and 7 a.m. Well, those are the sort of golden hours where therapy is capable of being turned on automatically. But the therapy is only delivered when the patient is recumbent, literally lying down with a certain degree of pitch, allowing for pillows or reflux wedges, and when the patient is lying down and inactive, not moving. When those two conditions obtain, within this therapeutic sleep window, therapy is turned on. But therapy is also paused during that period of time whenever the patient rolls around or when the patient sits up or stands up. And therapy resumes after a minute following a roll or after 10 minutes. If the patient gets up, for example, to use the restroom, it'll turn back on as soon as the patient, within 10 minutes of the patient becoming recumbent again and inactive. So this is a degree of automaticity that we don't commonly see for therapeutic respiratory pacing or stimulating systems. The response in central sleep apnea to transvenous phrenic nerve stimulation, the remedē system, is shown here, where a patient recovers from a roll during sleep on this polysomnographic recording, lasting several minutes in duration. And you can see for the period that therapy is off for a minute or two, this is a typical Cheyne-Stokes pattern with waxing and waning airflow and waxing and waning respiratory efforts. Periodic desaturations and arousal are natural accompaniments of a Cheyne-Stokes breathing pattern. After the timeout period, the therapy automatically turns on and begins very, very quickly to stabilize the breathing pattern, shown here with the airflow and the respiratory effort belts. But the system also recognized that breathing is a little bit choppy here at a lower level of stimulation, namely stimulus intensity at 3.7 milliamps. And it's only then that the system decides, if you will, to ramp up in stepwise fashion the level of stimulation until ventilation is absolutely captured. And you see here what results is a very, very steady period of respiratory effort and airflow or ventilation. A minor arousal, a movement, starts the process all over again. Stimulator turns off. We see the pattern of central apneas and Cheyne-Stokes breathing resumes. So this is automaticity that really maximizes or optimizes the amount of time during sleep that patients are stimulated. How do we know that it works? Well, a pivotal trial really demonstrated this. It was a randomized controlled trial. Patients with moderate to severe apnea with an AHI over 20 an hour, a predominance of central apneas, and a limited number, reduced number of obstructive apneas. The scoring of the sleep studies was blinded, so this was an absolutely blinded RCT. There was a treatment group where therapy was turned on after implantation, and a control group where therapy was turned off for the first 6 months and then turned on thereafter, constituting the former control group. The characteristics of these patients, both treatment and control groups, were matched for age, mid-60s, predominantly men, BMI of about 30, often with reduced ejection fraction and a history of heart failure in about 60 to 70% of patients, many of whom had atrial fibrillation in their history, a concomitant AICD, rather severe sleep apnea in the mean in the mid to high 40s, with a predominance, as mentioned, of central sleep apnea. The results of the RCT very clearly demonstrated a greater than 50% reduction in AHI that was much greater in the treatment compared to the control group. The treatment effect on AHI was largely accounted for by a reduction in the central apnea index. The arousals decreased by a commensurate amount, and as a result of stabilizing the breathing patterns, the patients didn't arouse so much, and they had increased amounts of REM sleep in the active treatment group. When patients breathe better during sleep, they sleep better, and they actually feel better during the daytime. And we found evidence of that with an improvement in the Global Quality of Life Index, the PGA, and improvement in daytime sleepiness, with the Epworth score falling in the treatment compared to the controls by 3.5 to 4 points, a very substantial drop in treatment. Well, you say, well, that's over the first 6 months of therapy. What about over 5 years? And you can see that the effects of transvenous phrenic nerve stimulation with the remedē system persist over the entire 5-year observation period. By this time, the controls have reverted to active treatment, and so the combined group was followed for 5 years, and you see that the overall AHI drops from the high 30s down to, at year 1, 2, 3, and up to year 5, a very low level of apnea. Largely, that improvement is due to the dropout, near complete elimination of central apneas, the orange portion of these stacked bars. And even if we account for attrition and look at matched pairs from baseline to 5 years, we see that the effect is robust. With compared to baseline, a mean AHI of 42, we've got an AHI well below 20, and effectively no or minimal central apneas at 5 years of ongoing therapy. Well, it's not just the sleep disorder breathing metrics that improve, but it's also the arousal index. The arousals go down dramatically over that 5-year period, whether you look at all comers into the protocol on the left-hand side or the paired or matched people who were followed up to 5 years. They too show a marked dramatic reduction in arousal index. And as a result, patients no longer experience nearly the degree of sleep fragmentation. The amount of light transitional stage 1 sleep, the orange bar at 5 years, goes down dramatically, and it's replaced by more stable amounts of non-REM stage 2 sleep and of REM sleep. These patients are clearly sleeping much more continuously, more soundly, and more deeply. And it's as a result of that we see that the apnea-hypopnea index reduction occurs across studies, no matter who has looked at it, compared to neutral, no change. Various studies looking at transvenous stimulation show a consistent 20 to 30 point reduction in AHI and the other effects on sleep architecture, beneficial effects on quality of life. It doesn't matter what subgroups we're looking at, the dots and the means are all favoring transvenous stimulation. Doesn't matter what your age is, whether you're male or female, your heart failure status, whether you've had an AICDs, whether you've got moderate to severe obesity or not, or a history of prior sleep apnea therapy or atrial fibrillation. All of these individuals in all of the subgroup post-hoc analyses show that they're on the forest plot, that a significant proportion of patients in each of these subgroups are achieving a less than 50% reduction in the AHI. Transvenous stimulation with the remedē system improves sleepiness and daytime quality of life, but also with few adverse events. We've commented already that the treatment, the actively treated group, improves their Epworth sleepiness scale by dropping their Epworth by 3.5 to 4 points. They improve their overall quality of life when we compare the actively treated group to the controls. And we've done so with a minimum of adverse events. 91% had no adverse events whatsoever, and the rate of implant-related lead revisions was fairly small at 3 or so %. Serious adverse events occurred in 6%, and there were no mortalities that were related to either the stimulation or to the treatment paradigm. When we crossed over the former controls, the former controls improved just like those that were randomized to active treatment. They look identical both in terms of the change in AHI, individual by individual. The same distribution of responses is seen here in the bottom graph as compared to the actively treated patients from the get-go. And those who were former controls that were turned on to active treatment show really effectively identical overall improvements in the Patient Global Assessment Quality of Life Index. We see as we drill down and we analyze the subgroup of people with heart failure, we see a similar benefit in sleep disorder breathing outcomes and in quality of life. In that post hoc analysis for this subgroup of patients with heart failure shows that every sleep disorder breathing metric improves, doesn't matter whether it's AHI, central apnea index, oxygenation, or arousal indices. The daytime Epworth Sleepiness Scale improves, and even a heart failure quality of life index, namely the Minnesota Living with Heart Failure Index, improves substantially, well above minimally clinically significant improvements in quality of life for patients with heart failure. And you see that represented here with the patient global assessment. Do you feel better? And the vast majority of patients report that yes, those with heart failure treated for their central sleep apnea feel a whole lot better than their controls who were untreated during the randomized controlled trial. It's not only quality of life that improves, but in this heart failure subgroup, we see that there's a modest improvement in those that are actively treated at 12 months in their left ventricular ejection fraction. There's actually a reduction in first heart failure hospitalizations, and it looks like there's no increase in cardiovascular death in this heart failure cohort that is treated with the remedē system. This is in contradistinction to the SERVE-HF ASV trial, where there was an increase in mortality in those that were actively treated. How do you apply the therapy? Well, the typical treatment pathway for the remedē system goes as follows. The device is implanted generally by an electrophysiology cardiologist, and therapy is activated. Literally, the stimulator is turned on at about 6 weeks post-implant. Over the first 3 months of activation, patients are acclimatizing to therapy. We initialize some therapy parameters, they get used to it, they become accustomed to it, and we're over time maximizing the efficacy of therapy while balancing off against patient comfort. And then in the 3 to 6 month time frame, we're actually looking in detail, sometimes with home-based monitoring or in-lab optimization studies to optimize therapeutic settings and to monitor patients for clinical results. Once this time elapses, we're generally looking anywhere with follow-up encounters in the 6 to 12 month time frame to check usage patterns, tolerability, effectiveness, and finally battery lifespan. So I'd like to summarize that central sleep apnea and chain stroke breathing is a highly important form of sleep disorder breathing for which there is effective therapy. It is, generally speaking, it is a form of periodic breathing that stems from increased loop gain. And the loop gain can be bucketed into 3 major categories: increases in controller gain, increases in plant gain in patients on CNS depressants, and increases in circulatory delay. Central apnea and chain stroke breathing disrupts sleep and really has a major impact on quality of life. And in the heart failure group of patients, it is highly linked to increased cardiovascular morbidity and mortality. There are specific therapeutic approaches that can address the underlying pathogenic mechanisms, with limited data to support treating the underlying heart failure, oxygenating the patient with either supplemental oxygen or non-invasive forms of positive pressure ventilation. But really, in the end of the day, the most reliable treatment that we've got that really abolishes central sleep apnea and chain stroke breathing is really with transvenous phrenic nerve stimulation. We've seen that with a randomized high level of evidence clinical trial, transvenous phrenic nerve stimulation with the remedē system provides a safe and effective treatment for central apnea and chain-stoked breathing. And as a result, leads to improvements in sleep architecture and quality of life. And it may, in fact, diminish heart failure, morbidity, mortality, and hospitalizations, really cutting off or stemming the tide of insults from repeated nocturnal adrenergic surges of adrenergic reactivity that lead to increased cardiovascular stress, cardiac remodeling, and adverse cardiovascular outcomes in the long term.